I'm Heather Bachert. I'm a nurse practitioner at Henry Ford Hospital in the interstitial lung disease program there, and I've been there for a number of years working with the ILD patients. So tonight we're going to talk about, this won't take too long. We're just going to talk about two more case studies following up on the session that we did over in Grand Rapids last week, I think it was. So you can move along to the next slide. Do you want to introduce yourself, Iris, as well?
And we want to thank Bollinger Ingelheim for sponsoring the WRAP talk about interstitial lung disease and the co-talk, which is so cool to do the talk with Heather. I am Iris Zink. I am a nurse practitioner from, my clinic is in East Lansing, Michigan. We have one in Okemos and one in East Lansing, Michigan. And I have been a rheumatology nurse practitioner for 26 years. And we have a Medicaid-based clinic serving the underserved in East Lansing.
So we're going to talk about a case here quickly. So it's about a journey through interstitial lung disease and rheumatic disease. So we'll talk about the case. It's called, I thought rheumatoid arthritis was all about the joints. And it definitely is about that, but there's more to underneath it all. So it's recognizing and managing rheumatoid arthritis, ILD. So the patient came in, a 67-year-old male. He presented with increasing fatigue and shortness of breath on exertion over the past 6 months. He had a past medical history of rheumatoid arthritis, and he was diagnosed 4 years ago. His rheumatoid factor was high, and his anti-CCP was as well. He was started on methotrexate, adalimumab, I think I said that right, was added as well a couple years ago because he was having ongoing disease activity. So the question with this is, what features in this history suggest a higher risk of interstitial lung disease? Well, he has a rheumatoid arthritis and it's seropositive. He's male as well. And then he started to have these symptoms of shortness of breath. So that gives us kind of a hint that something else may be going on. So we can move to the next slide. So on exam, he had these inspiratory crackles that could be heard. His SATs were fine at rest, but he did start desaturating when doing the walk test. So that's definitely right away a concern. I don't know how quickly he did, but anytime someone is doing this new, that's a big red flag. On the chest X-ray, he had the interstitial markings. So the breathing tests were ordered, or the PFTs, we call them, and the FVC was 65%, which is low, and the DLCO, or the diffusing capacity, was 41%, also quite low. And then we did an HRCT, and it showed these basal predominant reticulations with honeycombing, and that was consistent with a UIP pattern. UIP, remember, means unusual interstitial pneumonia. And it looks like a honeycomb often at the bottom of the lungs, but it can be throughout. So the question here is, what does the ACR and the chest guidelines from 2023 say? What do we recommend that we do next? So we can move to the next slide.
Wait, you have to explain you did such a good job the other night, and Kayla's on now. So if you can go back one, the FEV, because, would think that it's out of 100% and it's not, but
Right.
so it's kind of
forced vital capacity, the forced vital capacity, or FVC, his is 65%. So normal might not be 100, like Iris was saying. Normal might be closer to 80, 85%. But that measurement is how much we can blow out as long as we can, or as long as the patient can. And it's usually about 80, maybe 90%, depending on their height, weight, age, race. They kind of base it on that. So 65% is low, but it's not as bad as it kind of sounds. Does that make sense?
What if I've had a couple of patients this week. So what if his chest X-ray was normal as like an initial kind of testing thing, but he was complaining of more shortness of breath? You would automatically go ahead and go to the pulmonary function test and the high resolution CT.
Yeah, because if the chest X-ray was normal, it might not be picking up more subtle changes that the HRCT can pick up, and especially if he's still having symptoms after a little bit of time and the breathing test is not normal, I would go ahead and get the CAT scan. Okay, we can move to the next one, I think. And so Oh, so the question was what is the next step? I think referral to pulmonology to work with the team there would be recommended, and then they confirm the diagnosis that the patient did have ILD, more than likely related to the rheumatoid arthritis. That is all discussed in multidisciplinary conference among a group of providers that work with ILD patients as well as chest radiologists, and they usually conform a consensus there. So he'd been on the methotrexate for 4 years, and, the adalimumab, is that right, Iris? Started about 2
Humira.
years ago.
It's Humira, so
Close,
it's adalimumab,
close,
but it's
yeah,
Humira.
adalimumab. Started 2 years ago. Of course, we already talked about this. He had the high titer RF, older age, male sex, and the anti-CCP, so he was at high risk for ILD. Can you talk about the methotrexate quickly, Iris?
There is dissension amongst the ranks on this.
Yeah.
So over the years, people have always said, well, methotrexate can cause lung fibrosis. And then there was always like, no, it doesn't. And then there was like, maybe it does. And I think the last thing I heard was, no, it doesn't. So, but it does kind of shock me when we're going through this case that he was left on methotrexate for as long as he was, because generally we kind of try to get methotrexate on board. And if they're not better in 3 months as a treat to target, then we kind of move on to something else. So that probably didn't help us out that he was kind of left on sort of a lower active agent for as long as he was.
Right, right. And so the other question was what baseline and follow-up assessments would we establish? We definitely want to get the baseline PFT. We already did that. We got the first CAT scan. We already did that. And then we need to follow those. We want to follow those, breathing tests every 3 to 4 months or so, and definitely a chest or a HRCT every year. And then we're going to talk about his medications too and what we're going to do about that because evidently what he's on now isn't necessarily helping him.
Right.
Can
So
I
can we move
interrupt
to
and
the
ask
next
a
slide?
question?
Yeah.
Yes.
So with the follow-up pulmonary function tests, would that be something that the pulmonologist should be doing, or should we as rheumatology be looking at ordering those repeat tests?
I think that if the patient has access to pulmonology clinic, they should be following with them because then, we can kind of, make assessments based on that and anything else that he needs based on the lung part of things. But if the patient, let's say, kind of got lost to follow up, this has happened many times with pulmonology there, but they're seeing rheumatology and they kind of come back. You could, if you want, you could quickly get a breathing test if they couldn't get into pulmonary right away. But normally it would be followed by pulmonology, especially when he has this UIP pattern, he has ILD, he needs to be followed with a lung clinic.
Okay, perfect. Thank you.
Thanks, Kayla. Okay, so we can move to the next one. So yes, so what is the strategy? What are we going to do? The interstitial lung disease team or the pulmonology team started nintedanib, and that's one of the antifibrotics we talked about last week. So that medication can help slow the scarring down in the lungs. It doesn't take it away. It doesn't necessarily make them feel better, but it slows that scarring down that we know can advance quickly. And then also we switched them to abatacept for the rheumatoid arthritis control, and then they did end up stopping the methotrexate at that time. The other things, of course, making sure he's up to date on all his boosts or all his vaccines, the pneumococcal, flu, COVID, that kind of thing. And then, as we talked about, the monitoring. Um, so the antifibrotics, like I just said, it can help slow that scarring down. So that's the reason why we would start the patient on that. Rheumatoid arthritis can has a high incidence of ILD and it can advance quickly. So we certainly want to get them on that if possible. And then Iris, can you answer the question about the biologics?
Yeah, so it is kind of surprising that they switched him to abatacept because head-to-head studies have not really shown that abatacept is necessarily superior. The guy is double seropositive, so that the abatacept did show superiority in people who have double seropositive, but adalimumab works just as well. It's just non-inferior. So what I am surprised that we didn't pick here is something like Actemra, which is, I will tell you the name when I'm not on 3 hours of sleep here. But it's also an interleukin 6. It's an antifibrotic as well. So I'm kind of surprised because it is approved for rheumatoid arthritis that we didn't pick that one, which is tocilizumab.
Okay, we can move to the next slide. And so, um, just a summary about that case. So, high risk rheumatoid arthritis need proactive ILD screening, definitely. Um, the HRCT, the DLCO, which is part of the breathing test, play critical roles to identify early. And that UIP pattern, remember, that's that kind of honeycombing pattern that can be seen on the CT, carries a poor prognosis. So, if we get them on the antifibrotic medications, that can slow the decline of that. And we definitely need to collaborate with our rheumatology friends with that shared decision making. And we do that all the time. And so, and then I guess we can move to the next slide. I think there's another case. Do you want to talk about it, Iris?
Sure, I'll start. Case number 2 is getting harder to breathe, progressive interstitial lung disease and systemic sclerosis. So we've got a patient, her name's DA. She is a 56-year-old Caucasian woman who chief complaint is worsening dyspnea over the last 6 months with a dry cough, which is a red flag. Known diagnosis of diffuse cutaneous systemic sclerosis for the last 2 years. So you can go to the next slide. How we know that she has systemic sclerosis is because on the AVISE connective tissue disease panel or the ANA, DNA, ENA panel, she would have had a positive SCL70. And that is the systemic sclerosis is the one that causes skin thickening proximal to the elbows with Raynaud's phenomenon and also GERD. And she has a huge risk of developing interstitial lung disease, but she also has another risk of, because of systemic sclerosis, of pulmonary hypertension. So these patients need both kinds of screening, both for heart and for lung screening. So at baseline, we always do a pulmonary function test. We always get a chest X-ray on these patients. We do send them to pulmonary as quickly as we can, but we also do an echocardiogram in these patients just to see if they have any evidence of pulmonary hypertension too. You go to the next slide. Good. So because the worsening dyspnea over the last 6 months and she's desatting on exertion, we did the pulmonary function test and her forced vital capacity or FVC was 71% out of an expected 80% for this lady. And her DLCO is 52%, which is going down from where it was before. And maybe you can do better at explaining what the DLCO is for everybody who's listening.
Oh, yeah. So that one's part of the breathing test, part of the PFTs, and it's the diffusing capacity. So their ability to take up oxygen in the lungs. So when you start to see inflammation and scarring in the lungs, it's more difficult to exchange the oxygen. And so that number starts going down and down. And also it can be seen in going lower too in pulmonary hypertension.
So a high resolution CAT scan was ordered and it did show that early honeycombing with a UIP pattern. And the next steps in management would be hopefully getting her rapidly over to pulmonary. And then would you initiate transplant or refer to transplant? And this is, would you initiate treatment or refer to transplant? And this is shocking to me when I was learning about this, about how quickly you do refer to transplant or at least have that discussion. So can you talk about that?
So, just usually if the patient is getting close to needing oxygen is when we refer them to transplant. But if someone is getting worse quickly, we can start talking about it for sure. And if patients have a lot of honeycombing, a lot of scarring in the lungs, we certainly would mention like that to them. Now, they're not going to be listed yet if they were to go and see transplant, of course, if they're not needing oxygen yet, but they would be keeping a close eye on them. And it's kind of scary. So I kind of, bring it up. If someone's not needing oxygen and they just have lung disease getting worse, I just maybe bring it up, talk to them, let them know that that's something that is a possibility, down the road, I would say. And then we go from kind of there.
You don't want to take all of their hope away, right?
Right, right, right.
And then can you hit the next slide for me, please, Jen? Perfect. And so treatment that we could certainly initiate, it's systemic sclerosis is a real rough one because there is some data for treatment, but their treatments that we have in rheumatology have traditionally not been very great. you can use methotrexate, you can use MMF or myclophenolate. So this patient was started on myclophenolate and they were referred to transplant clinic for consideration. And then we talked about vaccine. And then when she got over to pulmonary, then Heather talked about palliative care options. And what role do non-pharmacological interventions play here? I love how you talked about pulmonary rehab. So can you speak to that? That was awesome.
Yeah, I was gonna talk about pulmonary rehab, because it's a program that we can refer patients to, and they go a couple times a week, even if they're on oxygen. And, usually there's a respiratory therapist there, nurses there, and they help the patients move through this program, kind of at their own pace. Like, they start them slow, and then they kind of can work up from there, but they usually do about an hour each session and, whatever they can do, but it gets them moving, it builds the muscles up around the lungs, it can help with shortness of breath. So it's a really good program that if patients have been sitting around home not doing much because 'cause they're so short of breath, it's a really good program for them. And then just with the palliative care, it really depends on what's going on with that patient. I don't know about this particular one, um, but if someone is, needing a lot of oxygen or not a transplant candidate, that kind of thing, um, perhaps that would be something to introduce at that point.
I think the pulmonary rehab is probably really good because they probably meet other people who are in similar situations too.
They do. Usually they love it. Usually they absolutely love it. It's a little bit hard right with the weather right now for a lot of folks. But usually once they get there, they really find it helpful. And then once they're done the initial program, which is several months, then they can do usually a maintenance program where they can kind of go on their own time and they're not needing quite as much attention, but they're still there and they can still get their oxygen levels checked and all of that kind of thing. And they kind of work at their own pace. There's usually a cost for that, a small cost, but usually people really like that as well. And then for monitoring and adjusting therapy, I was just gonna briefly touch on that. So being on the mycophenolate or other medications, they usually need their blood work checked every, maybe month in the very beginning, but maybe every 3 months after that, depending on how well they're doing. And then adjusting therapy, I guess usually Iris, for interstitial lung disease, 2 to 3 years of stability, and then we can start to wean down depending on how they're doing.
Right. And you would probably once this patient got over to pulmonary, you would also have that conversations about, the antifibrotics too, right?
Oh, absolutely, yes. It would be introduced fairly early, especially in a patient with, systemic sclerosis as well. And we already noticed that she had the UIP pattern, so she would more than likely be a candidate for that medication as well. So
So recognizing the high risk ILD and diffuse systemic sclerosis, but it can be in any disease for sure. Any of my autoimmune diseases like Sjogren's or rheumatoid arthritis, we see it in all of those diseases. And then importance of recognizing the progressive fibrosing interstitial lung disease and initiating immunomodulator therapy and timing the antifibrotic therapy. Again, this is the crosstalk between rheumatology and pulmonary and just making sure that everybody's communicating and getting to where they're supposed to be. And then timing of the referrals for transplant and the use of antifibrotics. And I love Heather the other day. She said that tissue is time. So if you wait too long, you've lost the tissue forever. So it's the faster you can get the patients on therapy and in for evaluations, really important.
that's so true because, and I'm sure you've seen this too, but you sometimes get patients who come to you and they're so far advanced in their disease. You look at the CT for the first time and the entire thing is, scar. And at that point, likely the antifibrotic isn't going to do much, because it's already advanced through the whole lung. So we want to see them early, even if they don't feel that bad, if they, you know, even if they feel okay. And a lot of patients, they do say they're okay. They don't notice their, change in symptoms till they're a little bit more advanced. So we would
That's
prefer.
true. I saw a patient today that another provider usually sees, and I saw this lady and I listened to her lungs and there's like crackle, 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 crackle. And she's obese and she's had rheumatoid arthritis for a while. And she told me that she said, I've had a change to my family history. My mother was recently diagnosed with antisynthetase syndrome. And I went, ah. So, and I said, are you short of breath? And she said, no. And I said, And I said, can you carry laundry up the stairs? And she's like, well, no, because the basket is too wide, but I can carry books up the stairs. And I went, yeah, we're going to do some testing on you. So it just, you have to lower your threshold of what the patient's saying and what you're concerned about.
Right. For sure. So, is that the
That's the last one.
Oh no, there's a little bit more. Okay. Oh,
What are your key takeaways across both cases? You go.
well, me, or should we talk to Kayla or Anna?
Okay, Kayla, go ahead. Kayla's really smart. So let's
Hi, everyone.
Hello. I think that for me, though, if I were to look at these two cases, is rheumatoid arthritis and scleroderma or systemic sclerosis are both autoimmune diseases that can have very significant lung disease. So those two patients that we talked about today, I would be concerned about, and I'd want to follow them very closely in pulmonary. So.
You have anything to add, Kayla or Anna?
Yeah, I really appreciate getting to see like the case studies like this so I can see because I recognize a lot of those situations with some of the patients that I see in our practice, Iris. I do have a question though, Heather, as you're coming from the pulmonology side, what makes like the most concise, effective referral for you to receive so that way you can say, yep, I know why this person is coming to me. What testing do you want the rheumatologist to do before we send them over so you have it and you're just ready to go and get them started so there's not a continued delay of tissue damage?
So for a new ILD consult, if we've never seen this patient before, it would be very helpful to have a CAT scan or any even chest x-rays, even belly scans, all of that kind of thing. We can see some of the lung cuts on those old tests. So we can go back and see when this actually started and how quickly it progressed. So if if that stuff is all sent over, so if you're going to refer a patient to pulmonary, send us all the information, send us the most recent CT scans, all that, chest x-rays, and even a baseline PFT would be great. But we don't have to have that, but the imaging is the most helpful. If they have old imaging, we'll look at that, we'll compare that, and all that kind of thing. So it helps with the diagnostic point. And then how you guys refer, I don't know how your system does it, but I presume that you put in like a referral electronically and that gets sent over to whoever you've referred to, whatever pulmonology team. But it would be great if it would be an ILD center or a pulmonary fibrosis center. But if it's not possible, then any pulmonology team.
And
I think here in Lansing, sorry, Iris, we only have the pulmonary or pulmonology. So I'm not sure if we have like a specific ILD team anywhere near us to refer to.
But maybe Heather can comment on places that are because she is at an ILD center.
So Henry Ford is, and so is University of Michigan, in Ann Arbor, and then Cornwall East, I believe. And then, it used to be Spectrum. You always used to be Spectrum, but I think they
It's
are
West now. Yeah, it's
Okay.
Cornwall West. Yeah, I know.
West. Okay,
Like
so
all the
I
health
would,
systems are conglomerates now.
yeah, I think that they would be an PFF center.
Yep.
Yeah,
Cornwall West is. Yep.
so they would have a lot of resources there for patients with ILD. So that would be the closest to you then, Kayla?
Fantastic. That would be a good spot to start because I've had patients that are willing to drive, especially out to U of M. We've sent quite a few people. So knowing that it might be beneficial to just get them out that way is good to know. Thank you so much.
Yeah, and I've actually heard really good things about the team out there at, I guess, Cornwall West.
Mm-hmm.
So that's near you guys. So I've heard really great things about their team. So, and their transplant team and everything. So I think you have some good resources close to you.
Perfect.
I did have one question, and I know I'm probably not supposed to ask questions, but now that the conversation is a little bit over, just wondering, there's a lot of discussion now on progression, right? And so trying to pinpoint at what point you would deem a patient progressive, I think has been difficult, especially within the autoimmune ILD patient population or just, non-IPF ILD, right? So I'm just curious, like your thoughts on at what point, you would determine that a patient actually is progressive. Of course, we have guidelines and whatnot, but just in your own clinical practice, I'm just curious, like at what point are you like, maybe I should either change therapy or send for an HRCT based on symptomology. And then at that point, whether it's, percent predicted FVC decline or amount of
Yeah.
fibrosis.
Yeah, so definitely if the HRCT is read by,
Yeah.
a chest radiologist, and that's someone radiologist who specialize in the lungs, and that is indicating that there is progression over the last year, that'd be one reason. Um, Decline in the PFTs by like around 10%. I know there's even
Right.
numbers now, but in the FVC and the DLCO too. And then if they have symptoms, I mean,
Right.
if there's one or two of those three things, then
True.
we might want to consider changing medications, around and talking with the team. What we do is we have our multidisciplinary meeting. So if there's a big change, we'll bring it to that meeting on Mondays. We have them on Mondays, with the whole team, with the radiologist, the pathologist, and the ILD doctors and nurses and everyone who comes to that meeting. We discuss that case. If there's something just more minor, we do it in our provider meeting. When it's just the providers, I could say, hey, this patient is, feeling a lot worse, and I'm worried because the PFTs are like really kind of dropping and she wasn't feeling well. And this is her CT. And then we all kind of discuss it and say, we probably need to, bring in our rheumatology friends and like talk with them and talk about maybe changing the immunosuppression, that kind of thing. Does that help? Does that help answer?
Yeah, no, it does. I think everyone's definition is a little bit different because you guys know your patient stuff. So, I just always like to ask because some people have a lower threshold for potentially changing therapy or whatnot. Sorry if you can hear my son in the background.
Oh, no. And I think
But
that if we think that their autoimmune disease is not controlled, then we definitely talk to our rheumatology team and say, hey, what do you think about their underlying condition? Could we switch the, meds and things?
Absolutely.
awesome. Thank you.
Thanks for listening.
And I think that last question there on the slide, what part of the diagnostic or treatment timeline do you feel most confident in? I think we got it with the PFTs and the HRCT. We got that part down. For me, it's more like recognizing some of their clinical symptoms with underlying autoimmune. That part, because it's not always the same in all the patients. So that part for me, I would be reaching out to you guys, Iris, to double check.
Thank you for joining us this evening, and thank you for Bollinger and Ingelheim for sponsoring. That was really great. And thanks for RAP for bringing us together, and hopefully we can get to do this again.